This program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest UCTV programs.
So good afternoon and welcome to the 5th Annual UCSF School of Dentistry Global Oral Health Symposium. My name is Benjamin Chaffee. I am the director of our program in Global Oral Health at the School of Dentistry, and I am delighted to see how many people have come out today to see our lineup and support our program, and I expect we'll see more people filing in as the afternoon moves along. So our program and our event, this is now our 5th year, has truly grown as the years have gone by. Really excited by the support we've seen. I think that speaks to certainly the quality of the lineup. We have some outstanding speakers to present today, and we're very proud to have them with us. I think this reflects a really growing interest in global health as a concept in education, as far as it applies to professional education among dentists. I strongly believe that the ideas of making sustainable impacts, of understanding the social determinants of health, of working in an interdisciplinary interdisciplinary way with our colleagues are all principles that are going to separate our graduates as true professionals as opposed to technicians of the mouth. So our theme today is nutrition, sugar, and oral health worldwide. And it's very tempting to say that this is a timely topic, that it could not be more timely as the effects of sugar and nutrition on our health become so profound. This is our 5th annual symposium, and there would not have even been a first if it wasn't for the leadership of Dr. John Greenspan, our first dean for global oral health here at UCSF. It is his vision and forward thinking that brought us all together and made this program possible. You'll hear me thank him many times, but first a thank you and applause to him.
So my name is Shel Amat, and I'm a 7th year student here at UCSF, finally graduating now as an orthodontist, studying global health as well, and an aspiring faculty member. And I have the pleasure of introducing our next speaker. All you need is love, but a little chocolate now and then doesn't hurt, right? Dr. Stuart Gansky over the break just quipped to me, "Man, this is a really sweet conference, isn't it?" So I asked our next presenter her opinion on how much sugar she thinks is okay in our diets. And she said, "Great question." And that's exactly what I hope to share with you in my presentation this afternoon. I'm very excited to have the privilege of introducing our next presenter and learning from her experiences. Among many other distinguished titles, Dr. Paula Moynihan is a professor of nutrition and oral health and director of the Center of Oral Health and Research at Newcastle University in the UK. She also is the director of the WHO Collaborating Center for Nutrition and Oral Health at Newcastle University, and all in such a short time. Her research interests include the interrelationship between nutrition and oral health throughout the life course and dietary intervention in older adults. Please excuse me as I read these. I want to make sure that I get it all right. Being an expert advisor on sugars and dental health to the WHO Nutrition Guideline Advisory Group, she led the recent WHO commissioned systematic review of evidence relating to the amounts of sugars and dental caries that has informed WHO guidelines on dietary sugars. Professor Moynihan has an amazing greater than 100 publications in peer-reviewed journals, several book chapters, and is on the editorial board for several scientific journals. She has presented her research at national and international conferences alike across the globe. Our next presenter has come a long way in a short amount of time, both figuratively and literally. Literally, she has traveled over many time zones to be here right now and is scheduled to give us a riveting presentation just about the time she would otherwise be sleeping. So to combat her ostensibly fierce jet lag right now, let's give the heartiest of welcomes to Dr. Paula Moynihan.
It's an honour and indeed a great pleasure to be invited here today to speak to you about sugars and dental caries. And I'd like to thank Ben Shafi, John Greenspan, and also the team at the university here for inviting me and for their kind hospitality. The intake of sugars in industrialised countries remains really high, and it's also increasing in countries that are undergoing economic transition. And this has led to concern that these high intakes of sugars are contributing to obesity and other non-communicable diseases, including dental caries. And periodically, the World Health Organization issues guidelines on nutrition, including recommendations for dietary sugars. So the main aim of my presentation today is to provide an insight into the guideline development process that was adopted by the World Health Organization when they recently updated their guideline for sugar. So over the next 40 minutes or so, I'm going to be looking at the classification of dietary sugars for health purposes. I'm going to summarise the WHO guideline development process and look at the recommendations for free sugars. And then I'm going to present the most up-to-date evidence on amount of sugars and dental caries that informed this process, and then look at how the current levels of sugars intake in both children and adults compares to these guidelines. And then I'll finish off by looking at the implications of these guidelines for policy and practice and what we need to do to help bring sugars in line with these new recommendations. So in March, the WHO issued their guideline for dietary sugars, and it recommended that the intake of free sugars by both children and adults should be reduced. And this was a strong recommendation, as was a recommendation to limit the intake of free sugars to no more than 10% of energy or calorie intake. Furthermore, it was suggested that there would be benefits of further reducing sugars intake to below 5% of total energy intake to protect oral health throughout the life course. And a remark was made that for countries that have low intakes already, the intake shouldn't be increased further. So what are free sugars? Well, dietary sugars include mono and disaccharides listed here, and added sugars are all the added mono and disaccharides, and this classification sometimes includes honey and syrups such as high fructose corn syrups, maple syrup for example, such as it does in the NHANES data. Natural sugars include those sugars that are physically located inside the cellular structure of grains, fruits and vegetables, and also those sugars that are naturally present in milk and milk products. Now, evidence shows that the sugars that are naturally present in fruits, vegetables, grains and milks do not make an important contribution to the development of non-communicable diseases and dental caries. And so it's the sugars other than these that have been classified as free sugars, and this definition is that it's all mono and disaccharides that are added to food by manufacturer, cook or consumer, plus those sugars that are naturally present in honey, syrups, fruit juices and fruit juice concentrates. And it's the intake of these sugars that we need to be limiting for health purposes. So the WHO in 2010 published a guideline development process, and it's available on their website. And first of all, what happens when they issue a guideline? They follow this process for all their guidelines, but the WHO draw up a protocol with a list of questions that need to be answered in the guideline, and they put the protocol out for external consultation and take on board comments. They then convene a guideline development group, and in the case of nutrition, it's called the Nutrition Guideline Advisory Group, or NUGAG, and they have a sub-panel on diet and health. So it's this group that then looks at the questions and sets the scope and priorities and the final protocol, and in this instance, they did it for dietary sugars and dental caries, and also for dietary sugars and weight gain. The WHO then commissions systematic reviews, and these are conducted by experts external to the NUGAG committee, and myself and Sarah Kelly at Newcastle University did the one on dental caries. And once the systematic reviews are done, the World Health Organization now use the grade process, which I'll talk more about in a moment, to first determine the quality of the body of evidence and then to set the strength of the recommendation. And this was conducted by the NUGAG group in liaison with the external experts. The recommendation is then drafted by the NUGAG and the WHO Secretariat. It's submitted to another committee, the Guideline Review Committee, who have the final say, and they issue it out for peer review and external consultation. The response is then obtained and it's considered by WHO before the final recommendation is issued. This process took 5 years. So it's a lengthy process, but I think it's useful to have an insight to it. For those of you that may not have come across GRADE, GRADE stands for Grading of Recommendations, Assessment, Development and Evaluation. And WHO use this in updating all of their dietary guidelines. A systematic review is commissioned, and from this, a general estimate of the effect of the outcome is obtained. Then the quality of the body of evidence is rated, and randomised control trials start with being high quality, and any other observational studies start being classified as low quality. But the evidence can be modified downward if there's things like inconsistency of results or publication bias. But the evidence can also be modified upwards if there's, for example, dose response, large size effect, etc. So once these factors have been considered, the overall body of evidence is rated as either high, moderate, low, or very low. Then the quality of the evidence is one factor that is taken into consideration when determining the strength of the recommendation, and it's considered alongside the balance of desirable and undesirable effects of bringing about the recommendation, the resource use required to translate the recommendation, and the values and preferences of the population. And so based on this, the strength of the recommendation is set as strong or conditional. So the strength of the recommendation is an indicator of the confidence that the desirable effects of adherence to the recommendation outweigh the undesirable effects. As I said, it can be strong or weak. The WHO tend to use the term conditional rather than weak. So strong recommendations is when it should be adopted as policy in most situations, or it definitely should be done. Conditional recommendations are issued when it probably should be done, but there's a need for more local debate and involvement of stakeholders for the recommendation to be adopted as policy. The systematic review that underpins the update of the guidelines asks these questions. First of all, what is the effect of a reduction or an increase in the amount of free sugars intake on dental caries? Secondly, what is the effect on dental caries of restricting sugars intake to less than 10% of energy intake? And finally, what is the effect on dental caries of restricting free sugars intake to below 5% of energy intake? The systematic review included all types of intervention and observational studies. The participants were apparently healthy humans of any age in any country. The exposure was intake of sugars or change in sugars, but measured in terms of amount, i.e. grams per day, kilograms per year, or percentage contribution to energy intake. And sugars included total sugars, free sugars, or any component of these classifications. The dental outcomes included dental caries measured as prevalence and or severity, DMFT, DMFS indexes. Now, I want to talk a little bit about the types of evidence because The WHO only considers epidemiological evidence conducted in human populations, of which we have the intervention studies. Of course, the gold standard is the randomised controlled trial, and then we have non-randomised intervention studies, but these can be open to bias. And then with respect to observational studies, we have the cohort studies that measure change in dental caries over time and relate it to diet, and these provide the strongest data after a randomised controlled trial. Then we have population ecological studies. These are studies that look at data on dental caries and relate it to per capita data on sugars availability, and so they have some more limitations. And then we have cross-sectional studies of populations. These measure levels of dental caries and intake of dietary sugars at one point in time. And they're a slightly weaker study design because we know that dental caries take several years to develop, and it could be the diet several years earlier that's responsible for the current levels of decay. If you've got somebody with the high caries, they may have actually reduced their sugars intake. So you need a little bit more caution when interpreting results from cross-sectional studies. And then we have what WHO classify as weaker forms of evidence, and these were excluded from the review. So it includes animal experiments, enamel slab experiments, plaque pH experiments, and simple laboratory incubation experiments. Although these add to our body of evidence on the impact of diet on dental caries, alone they provide insufficient evidence unless they're supported by data from epidemiological studies. So the data sources for the systematic review included all the databases listed here, as well as contacting experts and looking at the archives and the Centre for Oral Health Research. There were no age restrictions, no country restrictions, no date restrictions, and no language restrictions, and we translated all the papers into English as necessary. We found that the data went back to the 1950s. There were no randomised controlled trials. The available data came from non-randomised intervention studies, cohort studies, cross-sectional studies, and population-based studies. And there was much diversity in studies and the type of data reported, a point which I'll return to in a moment. 54 studies were reported in 65 papers that examined the relationship between amount of sugars and dental caries, and the vast majority of these were conducted in children, with only 5 studies being conducted in adults and 1 study in both children and adults. So the studies of adults included 2 non-randomised intervention studies, 1 population-based study and 2 cross-sectional studies, and the studies in children included 1 non-randomised intervention study, 8 cohort, 19 population-based studies, and 22 cross-sectional studies. Now, this next series of slides that I'm going to show you follow a similar format and illustrate the consistency in the findings across studies. So this slide shows the studies of adults, and here we have study type, first author, year, country, number in the study. But what I'd like to draw your attention to is this last column here, where a plus sign denotes a positive association between amount of sugars and dental caries, a 0, a neutral association, and a minus sign, a negative association. So here we can see for all the studies in adults, we see positive associations. Moving on to the studies in children, and here we have the findings of the cohort studies. Again, we see largely positive, 1 study finding no association. Here we have the population-based studies, again, largely positive. More population-based studies. And finally, the cross-sectional studies. Here we see a little bit more diversity in finding, which I think is largely due to the limitations of cross-sectional studies, which I've already mentioned, and some more cross-sectional studies. So if you didn't get that quick enough, here's a summary. 42 of the 50 studies in children and all of the studies in adults reported at least 1 positive association between amount of sugars and dental caries. 6 studies reported both positive and null findings. 7 reported no association. And 2 studies reported at least 1 negative association. But the positive associations covered all ages, developing, transitional and industrialised countries, and all decades of publication from the 1950s to the current day. Now, there was much diversity in the way that the data were reported, and this caused us problems because our initial aim was to do one overall meta-analysis. But we found that there was a range of outcomes reported for dental outcomes, DMFT, DMFS, percentage with caries, caries incidence, caries increment, changing caries, visible caries, etc., etc. You get the picture. And the same with sugars. Some reported total sugars, sometimes it wasn't clear and we had to find out. Some measured added sugars. But more importantly, the comparisons varied. So some studies compared dental caries between high and low sugars consumers, whereas other studies compared sugar consumption between high and low caries groups. There was differences or lack of information on fluoride, there was variation in length of studies and the years over which the studies were conducted. So, as I said previously, after randomised control trials, of which there were none, the next strongest study design, according to the grade process, is the cohort study, of which 8 were identified. All of these were conducted in children, and these were a grade analysis of the quality of data was done on this body of evidence. This slide, I'm not going to go through these in detail, but it shows the 8 studies. The ones in blue are in the primary dentition, ones in black permanent dentition, so there was 4 of each. And all but one study found a relationship, and there was evidence of dose response and also a large size effect. The study of McKeown that didn't find a relationship, the groups weren't entirely comparable because they were looking at low added sugars compared to high added sugars group, but the low added sugars group had a longer period of breastfeeding, and so that might have influenced the results. But nonetheless, of the 8 cohort studies, 7 showed a positive association between amount of sugars and dental caries development. 1 showed no association. And when the grade profile criteria was considered, this evidence was rated as being of moderate quality. So this answered the does increasing, does decreasing sugar impact on dental caries. But we went on to look at the studies that provided data that enabled us to look at levels of dental caries when the intake of free sugars was above with when it was below 10% of energy intake. And here we were able to do some crude meta-analysis by pooling data across study types that reported the dental outcome in a similar way. So this is a crude forest plot for data on dental caries that were reported as continuous variable, DMFT, for when there was information also on caries in those that were consuming above and below 10% of energy from free sugars. So data points on this side of the graph here favour low sugar, i.e. show lower caries when sugars intake was below 10%, compared with this side of the graph, which favours high sugar, showing lower caries when sugars was above 10%. These are the individual studies, and this is the overall data point which favours the low sugars intake. This is another crude forest plot of the pooled data for studies that had data on above and below 10% of sugars, but reported it as percentage with caries. And again, we can see that the pooled data favour a lower sugars intake. And then finally, the one study that reported the dental outcome as an odds ratio, again favouring low sugars. But the grade profile analysis was conducted on the cohort studies. So 5 of the 8 cohort studies had data that enabled us to compare levels of dental caries or caries development when sugars intake was above and below 10% of energy. And all of these studies were conducted in children. And this slide shows these 5 studies, again with the permanent dentition in black and the primary in blue. Rottenen found that the low sugars group, who were consuming less than 10% of energy, had 0.5 DMFT compared with 1.4 in a group of children that had had sugars intake above 10% of energy from birth. Sticks and Blix found in a low dental caries group the sugar intake was below 10% compared with above 10% in a high caries group. Rugg-Gunn found that the highest free sugars consumers developed 0.9 9 more decayed surfaces per year than the lowest free sugars consumer, and found a dose response between the intake of sugars and dental caries. Rodrigues in Brazil found that children were more than almost 3 times more likely to have high levels of dental caries when the intake of free sugars was 16% of energy compared with when it was below 10%. And Karjalainen in Finland showed that the sugars intake in those that developed caries was above 10%, whereas it was below 10% in those that remained cavities-free. And the grade profile analysis that was done on these studies rated these data as of moderate quality. But we still see dental caries at 10% of energy intake, and that's what this slide shows. It's the same 5 studies, but this slide highlights the level of dental caries in the group consuming less than 10% of energy as free sugars. So Rodrigues et al., the children developed 1 cavity. Karjalainen, no cavities developed. Ruutanen had 0.5 DMFT. In the study of Gunn, the children developed 3.2 caries surfaces in 2 years, and in Sticks and Blix, children developed between 0 and 2 cavities in 1 year. These are low levels of dental caries, but dental caries is a cumulative and progressive disease. And furthermore, these data were measured at the cavities level, which is a late stage of disease. So I'm sure you're all more familiar with indices for measuring dental caries than I am, but I am familiar with the ICEDA score system where caries is ranked 1 to 6 from the very, very earliest subsurface demineralization up to full cavitation. Now, most of the studies and the epidemiological data have used the WHO criteria, which probably includes stages 4 to 6 when cavitation has occurred. So to say caries-free in these studies, what they actually mean is cavities-free and not totally free of dental caries activity. So we still see dental caries when free sugars intake is below 10% of energy intake, and also looking at data from trajectories of dental caries, we see that it increases with age. So, for example, being free of dental caries at age 12 doesn't mean being free of dental caries for life. There are data from the Dunedin longitudinal study that show children aged 12 that have less than 3 DMFS go on to develop 15 DMFS by the age of 32. There's data from the USA that shows a year-on-year increase in caries increment in adults even when there's exposure to fluoride. And a recent analysis by Burnaby and Shyam have looked at the age, period and cohort effects on dental caries in 4 countries, including the USA and England and Wales, and have found that dental caries increases of age independent of period and cohort effect, and that most dental caries is now occurring in adults. So what this means is that even small reductions in dental caries in childhood are of significance because of the progressive nature of the disease. Now, back at the end of the 1990s, the World Health Organization had a goal for the year 2000 that the average DMFT of 12-year-olds would be below 3. This goal is now outdated. Really outdated. That is no longer considered low. And the Alliance for a Cavities-Free Future have interestingly set a goal that every child born after the year 2026 will be free of cavities for life. So bearing this in mind, we went on to answer the question, what is the effect on dental caries of restricting sugars intake to below 5% of energy intake? Now, there were very few epidemiological data of populations consuming low levels of sugars intake, and the best available data came from population-based ecological studies of which the dental data was based on dental surveys of Japanese school children that were conducted before, during and after the Second World War. This was a period during which the intake or the availability of sucrose decreased from a pre-war value of 15 kilograms per person per year down to as low as 0.2 kilograms per person per year. So these data enabled us to look at levels of dental caries when the intake of free sugars was below 5 5% compared with when it was above 5% but below 10% of energy intake. And all of these studies showed lower dental caries levels when sugar's availability was below 5% compared with when it was between 5 and 10% of energy intake. And furthermore, they all showed strong log linear relationships between sugar's availability and dental caries over these low levels of sugar's intake. Now, a grade analysis of these studies, of this body of evidence, was conducted, and due to the limitations of ecological studies, it was rated as being of very low quality. But I think that we need to interpret this alongside the fact that we still see dental caries at 10% sugars intake, and we need to protect oral health throughout the life course into old age. It's not just about preventing dental caries in children. We're now seeing higher levels in adults. So the outcomes of this systematic review were published in the Journal of Dental Research in January 14, should you want to read up any more about it. But what I want to do is move on and look at how current intakes of sugar compare with these recommendations. And I'm going to look at data from both the USA and the UK. So these are data on the added sugar intake that were taken from the NHANES survey of children and adolescents in the USA between 2005-2008, and this is work published by Irvin et al. In 2012, so it provides it for boys and girls. So we can see that even in the really youngest age groups, about 13% of energy as added sugars, increasing to about 17% by adolescents for the boys. And in this report, Irvin also reported that the non-Hispanic white children and adolescents had a higher intake than Mexican-American children, that there was no difference according to income, which was interesting, that more added sugars came from foods rather than beverages. I'm going to return to that point in a moment, and that more calories from added sugars were consumed at home rather than away from home. This slide shows some data that we have from the UK, where we've been doing repeat dietary surveys of children aged 11 and 12 years since the 1980s. So it shows the intake of free sugars and the intake of total sugars in 18, 19 and 2000. I must apologise that we haven't quite got the 2010 data ready to share with you yet. But the intake of free sugars has remained stable at high, about 16, 17, 16% of energy intake, with total sugars providing 22. But what has changed over the decades is where children get their sugars from. So what we can see here, this is the percentage contribution of different food groups to total sugars intake, and we see this is from 1980 to the thousands, and we see the intake from soft drinks has rocketed. It's actually gone down from sweets and confectionery. Biscuits and cakes has gone up. I think this is due to people buying biscuits and cakes which have a high level added to rather than baking them in the home. Breakfast cereals has gone up. This is because people buy their sugar ready sweetened now as opposed to buying it unsweetened and adding their sugar themselves. Table sugar's gone down, and the contributions of puddings has gone down. But together, sweets and confectionery provide over 60% of intake, and these are the items that also tend to be consumed frequently and in between meals when they can be most damaging to teeth. So even though the American data showed that contribution from food, which would be all these sources together, was greater than drinks, I still think that you'll find that there's a large contribution from soft drinks. What about adults? They're not. We also need to be concerned about added sugars, free sugars intake by adults. And in the UK, our National Diet and Nutrition Survey has shown that adults get just under 12% of energy from free sugars. The NHANES data that was recently published that I found showed that in the 20 to 50-year-olds, around just over 14% came from added sugars, and this was lower in the 50-plus age group at 11.6%. But these values won't include those free sugars that are found in unsweetened fruit juices, whereas our values in the UK do. Now, I'm often asked, why did the WHO consider amount of sugars only, when quite often it's argued when it comes to dental decay that frequency is the important thing? Well, I'd like to argue that there's actually very little data out there on the impact of daily frequency of free sugars intake from all food sources and the development of dental caries. Of course, there's many studies out there that have used food frequency questionnaires looking at the frequency of sugary items such as confectionery, soft drinks, and quite often they say how many times a day, week, month do you have these foods. But the important factor is daily frequency. And only studies that have measured both daily frequency and daily amount of sugar simultaneously can conclude which variable is most important. And those studies that have, for example, that done by Ruggun in the UK, Burt in the US, actually found stronger relationships for amount. But that said, there is a very strong correlation between the two variables. So efforts to control one should control the other. Now, I think frequency is a really useful health education tool, a chairside tool, because when you're giving advice to a patient to reduce sugars intake, it's a lot more tangible to the patient to say how many times a day, or to look at how many times a day they're consuming sugary foods and get them to work towards reducing it. But at a WHO policy level, it's really important that we have a goal in terms of amount, an evidence-based goal in terms of amount, because not only is this the way that guidelines are usually set, but it also provides a benchmark against which the intakes of populations can be compared and the success of strategies to reduce sugars judged. Also, reducing frequency alone will have no impact on obesity or other non-communicable diseases that are associated with sugars consumption. So what about different types of sugar then? This is something else that I'm often asked. Well, with the exception of lactose, the kerogenicity of mono and disaccharides is fairly similar, and there won't be a great advantage of swapping one for the other. There's animal and plat pH studies that shows lactose is less kerogenic, and epidemiological studies show that milk has a neutral or negative association with dental caries development. Some animal studies show sucrose to be more kerogenic. In some of these studies, the animals were superinfected with S mutans. The Turku sugar study, which was a non-randomized intervention study in adults, showed no difference in the development of cavities between groups that were following fructose or sucrose diets. But when you included the precarious lesions, then I think that there was a higher development of caries in the sucrose group, and that might suggest that sucrose has an important role in the initiation of caries. We've already heard sucrose is important in the synthesis of extracellular glucan, and the work by Dom Zero has shown that this is important in enhancing strep mutans and increasing the porosity of plaque, which can mean that the acid environment close to the tooth is increased. But that said, the WHO considers that all free sugars to be of risk for dental caries and also for other non-communicable diseases such as obesity. They've all got similar calorie intakes, contents, I mean. And what about fluoride? Well, fluoride has been one of the most effective strategies in reducing dental caries. I don't need to tell an audience like this that. But the relationship between sugars and caries still exists in populations exposed to fluoride. And in the WHO review, all of the cohort studies that compared the high and low sugars intake, the fluoride exposure was similar in the groups. They all accounted for fluoride. This slide shows a study that is very old. It's very old, but it's one of my favourites, and that's not only because it was conducted in Newcastle, which is where I now work, but it also shows the additive benefit of fluoride and sugars reduction. In Newcastle, there's a river that goes through it, the River Tyne, and in South Shields, that is south of the River Tyne, the water is naturally fluoridated at 1 part per million. So if you were a child in 1943 living in that area, you were pretty lucky because your DMFT was almost half that of those that lived on North Tyne side, north of the Tyne, where the water was naturally low in fluoride. So already we see the benefit of the fluoride in the water on dental caries. But then along came the food rationing of the Second World War, and the intake of sugar plummeted, and those that didn't have the protection of fluoride benefited from this in that their DMFT decreased, but those that already had the benefit of fluoride, their dental health improved further. And so I think it's important that we consider both sugars reduction and fluoride. If you focus on fluoride alone, you need to be a good mopper. Fluoride helps to mop up the damage that is caused by dietary sugars. It's a lot easier to switch the taps off. Now, any talk on diet and dental caries wouldn't be complete unless I considered other carbohydrates. The diet of the population is changing. It's increasingly containing an increasing array of processed, starchy foods, etc., etc. So this slide shows two groups of starchy foods, because starch, it varies in nature. It can be cooked, it can be unprocessed, it can be treated in all so many ways. But the non-processed starch, or what I call the starchy staple foods, breads, potatoes, unsweetened cereals, rice, pasta, millet, these are the starchy foods that nutritionists are saying eat more of, get lots of your calories from these. Processed starchy foods are the corn snacks, pretzels, sugary breakfast cereals, sweetened bread, biscuits, cakes, sugared popcorn. These foods are also high in fat, quite often, salt, and many of them have added sugars. It's not the intake of these foods that dietitians are saying eating more of. These foods are likely to contribute to non-communicable diseases and also to dental caries. So let's take a look at that evidence now, and I'm going to start off with the weakest form of evidence leading up to the strongest. So we know that starchy foods like crisps, pretzels, breadsticks, I can't even talk now, it must be that jet lag, crackers and cornflakes, if you hydrolyze them with salivary amylase, yes, saliva will break them down to glucose, maltose, maltotriose, and then they can be metabolized by the oral bacteria to produce lactic acid. So when it comes to these foods, oral retentiveness is really important. We see from PLAT pH studies that foods containing cooked starch and processed starches do produce acid. They will drop the PLAT pH, but an awful lot less so than sugars. And there's work that shows that starchy staple foods decrease PLAT pH, but not below the critical pH. Enamel slab experiments, which is getting a little bit closer to reality, these show that cooked starches cause approximately a quarter of the demineralization that you see with sugars. And then we have the animal studies that show that cooked starch can cause caries but less than sugars. But if you mix cooked starch with sugars, you can get caries of levels similar to that seen with sugars alone. But let's look at the epidemiological evidence, because human epidemiological studies are the only study type that measure the impact of dietary starch on the development of dental caries in humans. And these show that the older studies show that when starch intake is unaltered or increases and sugars goes down, caries goes down. There's also from the some of the older research showed that when you look at the relationship between cereals and dental caries, but you control for sugars, you don't see the relationship. And the WHO in the 2003 report said there was convincing evidence that starch-rich staple foods show no relationship with caries. But our diets are changing, and these starchy snacks are on the increase. And when I looked at the data, there are very, very few epidemiological studies that have looked at intake of all sources of processed starches or unprocessed starches and related it to dental caries. But there are some good data from the Iowa fluoride study, and this study has shown a significant association between the consumption of processed starchy foods as snacks and the development of dental caries in young children. And interestingly, they didn't find an association between the consumption of the unprocessed starchy staple foods and dental caries. But there is a lack of data in this, and we do need really good cohort studies that look at this. A lot of the dietary surveys just look at total carbohydrate. That doesn't tell us what we need to know. We need to know the relationship between processed starch and dental caries, unprocessed starches, and added and free sugars. Now, if we're going to bring sugars intake in line with the WHO recommendations, we're going to need effort at a lot of levels. We're going to need to produce and import less, use less, sell less, market less, advertise less, and ultimately eat less. If we put all our efforts into this downstream health education, we really are fighting a very difficult battle. We need these upstream approaches to support the efforts further downstream. And this is what I want to talk about now. So the WHO guidelines set the precedents for and guide national policy makers when updating national policy. And that's really important. We need to see now revision of national policies. We need to consider taxing of foods high in free sugars, such as sugar-sweetened beverages, and reformulation of products high in free sugars to lower sugars intake. Kristen mentioned the food labelling of free sugars, and I'll return to that in a moment. We also need better education of professionals, but not just health professionals. We also need to educate carers, teachers, and those working in the fitness industry. And we need to have messages that are consistent across professions. So dentists need to learn more about nutrition, nutritionists need to learn more about dentistry, and we all need to say the same thing. So we need a core curriculum. At the moment, my guess is that we all teach something different. And then finally, we need health education and consumer messages from early years to schools, care, the workplace. And finally, and not last but not least, dietary advice in dental practice. I sometimes hear people say, oh, you know, dietary modification in dental practice doesn't work. There's no evidence it works. But what I'd like to say is that there isn't evidence that may be no evidence that it does work. It's because it hasn't been researched. So there's no evidence that it doesn't work. And we need more research into effective behavioural interventions in the dental practice. I just want to mention a few of these upstream approaches before I conclude my talk. In the UK, our Scientific Advisory Committee on Nutrition has issued draft guidelines for carbohydrates. And they are now, in the draft guidelines, it says that the dietary reference value for free sugars should be 5% of calories from the age 2 years upwards. And this is based on the need that at the level of the individual, no more than 10% of calories should come from free sugars. So if everybody consumes less than 10%, then the population average should be around 5%. We've already seen this report today. This is the revised US dietary guidelines, which is out for consultation. Again, this says less than 10% of calories from added sugars, but when I read through this, it seemed to me that this applied for individuals. So if this report is recommending that individuals within the USA should consume less than 10% of their calories from added sugars, it means they've adopted the 5% guideline, because the population average would need to be around 4-6% to make everybody have less than 10%. So I welcome your views on that. Looking at taxing of sugar-sweetened beverages exists in several countries such as Norway and France. It has done for a while, parts of the USA, but its effectiveness hasn't been fully evaluated. And at the moment, what we're seeing is a lot of research into policy simulations. And there's this recent one that I want to share with you that came out of Australia, where they looked at the effect of a 20-cent tax, 20 cent per litre tax on sugar-sweetened beverages, and they looked at it by by band of consumption from low to high, and they found that the greatest effect would be on the high consumers of sugar and sweetened beverages, despite the fact that a tax is less of a deterrent for this group. It's what we call price elasticity, the impact that price hike has on your consumption. And they estimated for the highest consumers that such a tax could lead to an 8-gram free sugars reduction a day. That's 2 level teaspoons of sugar. So that's a sizable achievement. Even if a price hike didn't deter people from, the actual price hike per se didn't deter consumption, putting a tax on the product does send out a clear message to the consumer that the product isn't healthy. Reformulation of foods and drinks to lower their sugars intake is another thing to consider. It's been considered very seriously in the UK. It benefits the consumer without requiring a change in behaviour. But it does depend on consumer acceptance. So when manufacturers reformulate products, they do it gradually over a period of years so that you don't notice the taste change. We have sugar puffs in the UK. When I was a kid, they were sugary. You tip them out of the box and they were just in one great big lump stuck together with sugar. But over the years, they've reduced the sugar considerably. They're still sugary, but they don't stick together anymore. So that really works quite well. But what we're seeing with reformulation of sugar is that the manufacturers are replacing the sugar with non-sugar sweeteners, and although this will lower sugar's intake, it doesn't actually get rid of someone's desire for a sweet taste. And it would be nice to see reformulation so we get used to having our food less sweet. And we need more data on the consumption of the reformulated products. Now, this has worked well for salt in the UK because it was a level playing field that all manufacturers signed up to. And I don't know whether or not that's actually going to work for sugars unless there's legislation to support it and back it up. Clearer labelling, well, I don't really need to show you this slide because Christine covered it in hers, but it's so good. I really hope that this comes in with the added sugars. People get so frustrated when they look at a fruit yoghurt and you don't know how much is added sugar because some of it's from fruit, some of it's from lactose, and some of it's added. This labelling will get around that. You will automatically see how much is added. And of course, if you guys do it in the USA, we'll copy you because we always do. So, our Public Health England has an action plan, and they state that reducing free sugars is now a priority, not just for obesity prevention, but prevention of dental caries. If you listen to the media, you might think sugar was a poison, it was toxic, it was the new tobacco, and that we should all be having a sugar-free diet. 5% isn't a sugar-free diet. 5% probably allows you to have one sugary treat per day. And this slide shows what 5% looks like in food terms. So I don't know whether you have bran flakes in the USA, but it's a medium portion of a breakfast cereal with milk and a small glass of unsweetened orange juice. It's a donut and a glass of lemonade. It's a mug of hot chocolate, a tea with 1 sugar and a slice of carrot cake or another cake, 15 digestive biscuits, preferably not eaten throughout the day. It's a glass of cordial drink made with 50 ml of concentrate and a cereal bar, 2 fun-sized chocolate bars, or a 5-ounce low-fat fruit yoghurt and half a cup of granola. So my message is that it does allow for a sugary treat. It's not a sugar-free diet, but the word is treat. Sugar has become a staple in the diet. It should be a treat, and we need to reverse that trend. Well, I know that my 45 minutes are just about up, so I'd like to draw my presentation to a close by concluding that the WHO adopted a robust and objective process when revising the guideline for sugars intake. An intake of sugars below 10% of energy is associated with lower risk of dental caries and lower risk of weight gain, and the WHO have made a strong recommendation to populations to have no more than that level, but they've also made a conditional recommendation to limit it to 5% because we still see dental caries at 10%, and with respect to obesity, the less you have, the better. Intakes are currently above this, and so there's considerable action that we need in order to make these guidelines translate into a reality. But this requires an upstream as well as a downstream approach to prevention. We need policies, we need taxing, reformulation of foods, clearer labelling, better education. It's only with this concerted effort that we will successfully translate the goals into practice and safeguard dental health throughout the life course. Thank you for your attention.
Hi, my name is Rebecca Berner. I'm from El Poder del Consumidor in Mexico. We were one of the organizations who worked on the sugar-sweetened beverage tax in Mexico. And we have, until recently, a 90-gram GDA food and beverage label, and congratulate you fully on everything that was done with the WHO recommendations. What would your advice be to advocates? What can we do now to make sure that they're adopted, and to support you in getting the word out so that governments follow them? Because a recommendation is wonderful. Yeah. It's allowed the Mexican government now to come out publicly to say that they'll be changing their GDA label, which had a recommended intake of up to 90 grams, and to say that they're going to be one of the first countries in the world to adopt them. We're waiting to see that happen. And what comes next? What do you recommend that we do, and how can we support one another better?
Okay. I mean, with respect to the GDA, that's usually based on the adult values for intakes. And so if you were wanting all adults to have below 10%, so that your population average was 5%, then you would want your GDA to be below 50 grams per day. So it's almost halving it. Yeah. Your second question referred to what snacks we could recommend, was it?
No. What could we do together to make sure that governments actually adopt the recommendations? How do you think that we should support one another from the academic and advocate communities?
That's an interesting question. I know that the WHO have a system called GINA, where people can put information on the policies and the things that they're doing so that we can share good practice. And they are actively going to be collecting information on things that are happening, and anyone can sign up to look at this and see what's going on. And I think it'd be really good if people did that, so that we could look at what's happening in different countries, so that we can copy each other. Okay.
Okay, why don't we hold our questions for the panel? Let's bring up all our speakers and we can begin our panel discussion.
And thanks very much. People have been saying nice things about me today. I appreciate that. You always know why, of course. Sort of, you know, you get to the point in your career where less is done and more praise is lauded on you. But actually, I've done nothing in the field of today's topic of caries and of sugar. And there are some people on our faculty who've done remarkable things. Howard Pollack has stood by fluoride in really very difficult times, and John Featherstone has a glorious career in cariology. There's one person I do want to kind of dedicate the day to, and that's Ernie Newbron. Ernie has been one of my mentors and muses, and so you won't mind me telling a story. But we've been talking about medical dental connections today. I'll give you the supreme one. I think it was the second edition of your textbook, Ernie. His textbook is Cariology. It's actually still, it's so good that, you know, even though he hasn't done an update in a long time, we still use it a lot. And I remember he gave me, proudly gave me a prior pre-publication copy of the second edition. It was green, Ernie, I remember. And I looked at the spine of the book and it said cardiology. So there you are. Ernie was well ahead of the field. But Ernie did so much for the field of dental science. Of course, he ended up as president of the IDR. But his own particular work on caries, spanning a field that now we would call clinical and translational science, right down to basic science, was very innovative when he did it. He started out as a dentist, a pediatric dentist, a biochemist, a clinical scientist, and the cariologist par excellence, and then actually acquired a second specialty in periodontology and was a clinical periodontologist for many years. So Ernie's a remarkable man, and I just want to praise him. Well, you know, after a wonderful afternoon like this, one is tempted to say that it was a feast for the senses, you know, the intellectual senses, that the flavor that the experts brought because of their wonderful knowledge. But since we're talking about sugar, I don't think I should be using analogies such as that or metaphors such as that. Instead, I'll let you all come up with some comments and suggestions for how we might make the next 15 or so minutes the climax, if you like, of what has been a wonderful afternoon. So while you're thinking about coming up with questions, let me pose a couple, if I may. And my first one really relates to this wonderful program of putting food content on labels. And, you know, I love the new one. That looks terrific. And when I go into stores, if I've got my reading glasses on, you know, look. But I don't see many people doing that. So my question to you with these labels is, what's the point? Does it really achieve anything?
I'd say in the UK, as well as that nutrition label, we also have a traffic light scheme on the front of our pack. So it's red if it's high in sugars, it's amber if it's medium, and then green if it's low. And that's really great if you've forgotten your reading glasses, because you can see instantly from looking at the pack. And I think there has been research done in the UK to show that people use that more than they actually look at the grams per 100 grams. That's what us geeky nutritionists do, I think. But I think a traffic light system is really useful.
So that's the thought. But is there any data showing that the labeling does anything?
They've looked at it in food stamp recipients and in select population cohorts, but there's been no good cross-sectional studies on it. Every time the food labeling changes, massive education campaigns come out, and they look at consumers and they look at professionals, and they're literacy-based, multi-languages. What we need to start looking at, though, I think, and it brings it back to this audience, is that whole interprofessional education on it and teaching health professionals to enforce it in their settings as well. But it's a good market for further research, that's for sure.
Ah, good. We need that. Stan, you're going to answer the question because it works with tobacco, or do you want to ask a different
Can I
question?
add one more thing? I'm sorry.
Do you want to say something?
I did want to just add one more thing
I'm
to
sorry,
your question.
Kristen.
I think another key point related to the added sugars label is what that could do for limiting health and promotional claims on the front of packages. So the huge lettering of fat-free. I've got a box of Cocoa Pebbles in my office that has this massive blue bar across the top that says gluten-free that you can see from across the room. So we could reduce some of those labelings that certainly have an impact. Otherwise, the food companies wouldn't use them.
I think the best evidence that the label change would be a good thing is how hard the food companies fight it. And a colleague of mine from Australia in tobacco, but who also works in these other issues, many years ago came up with what he called the scream test. And he said you can measure the effectiveness of your program by the response it provokes, and the louder they scream, the better it is. So there are metrics of effectiveness that are different than randomized controlled trials. But anyway, my substantive comment is about evidence and interpretation of evidence, because, I mean, I really like the report you came up with and the WHO's sort of what you ended up with, but I think that the way, at least, that you describe the process really denigrates animal evidence, non-randomized clinical trials, and I think that's really terrible. And I serve on a panel for the state of California that deals with air pollution, and we're confronted with these questions all the time. And I really think a much better way to do it, which you kind of did in your talk, is ask your question, does all the pieces hang together? And is the animal data consistent with the clinical trials? Because when you're dealing with a lot of population level interventions, you either can't do a randomized trial or it wouldn't make sense even if you did. And so, you know, the fact that, yes, if you have an in vitro test or an animal study, that's quite different from a human study, and there are many limitations. But the nice thing about those things is you have a lot of control, which you don't have in a population-based study or even in a lot of clinical trials. And so, since you're plugged into the WHO process, what we do for Cal EPA is we try to look at the body of the evidence and the consistency of the evidence, rather than saying this kind of study is better than that kind of study.
Yeah.
Thanks, Dan.
I need to comment on that
Please
if
do.
I can, because I wasn't saying that those types of studies, such as animal studies, don't have a place. In fact, of course, that they do. What I was saying, and actually when the WHO looked at the evidence in 2003, they did look at evidence from all sources. And when evidence was only from, say, animal studies or clinical experimental studies, then it was graded slightly lower than it would have been had there been evidence from human epidemiological studies. This time round, and it's a WHO thing that goes across all nutrition guidelines, is that they are just looking at epidemiological data. So what I was trying to say was, because alone, when those, and what happens sometimes is people take data from a study and interpret it in isolation. Like, we've got a plaque pH study. Oh, look, white bread causes as much of a decrease in plaque pH as something, therefore white bread's just as bad for you as sugars. And it's that misinterpretation. So I agree with you that you need to look at the entire body of the evidence, but the WHO process only looked at the epidemiological evidence.
Why aren't we doing sibling studies where you give the intervention to the 4-year-old, particularly with dental caries, the 6-year-old, the 8-year-old, they have virtually the same DNA, they have the same parents, the same food, the same habits. So you give the fluoride to the 6-year-old, the 4-year-old, and the 2-year-old, but by the time the 2-year-old is 4 years old, you can compare their caries rate with the 4-year-old at the beginning of the study, and the 4-year-old with the 6-year-old. I don't see those studies, and that would overcome the ethical problem, the cost problem.
It would be more difficult to do it for diet, because unfortunately it's very difficult to get people to adhere to dietary regimes for the period of time that's necessary to see a change in caries development. But I agree with you, we can't do randomised control trials because it would be unethical to have a positive control. But I think what we need are cohort studies that have modern day design, that measure free sugars or added sugars using a robust dietary methodology, and that use up-to-date methods for scoring dental caries. And I think we do need to continue to do cohort studies, because diets do change over time. And we have some good cohort data. It would be nice to see more good quality cohort data, especially data in adults.
Yes.
Pamela?
A couple of years ago, I read an article in the New York Times Magazine entitled "The Extraordinary Science of Addictive Junk Food." And I just pulled up the article, if I could just read a quote from it. But do you remember the Lay's commercial, "Bet you can't eat just one"? Mm-hmm. Well, anyway, in the article it was written, the coating of salt, the fat, content that rewards the brain with instant feelings of pleasure, the sugar that exists not as an additive but in the starch of the potato itself, all of this combines to make it the perfect addictive food. The starch is readily absorbed. More quickly even than a similar amount of sugar, the starch in turn causes the glucose levels in the blood to spike, which can result in craving for more. So I just feel like the food industry is, of course, we know, conspiring against us. They know our limbic brains love sugar. So is there hope? You know, you can see nutritional content and how much you should eat, but that's going to be really difficult to overcome. Please comment on that.
Thank you, Pam.
Well, I just don't buy them because I know if I open a packet, that's it.
Just say no.
Howard?
Thank you for wonderful presentations. So while each of you was presenting, I was thinking of my own personal experiences, as I'm sure others were. And Reva, you talked about the effects of treatment of oral cancer or head and neck cancer. My father died from oral cancer some 16 years after it was diagnosed and treated. And of course, dry mouth was one of the concerns he had, and also mucositis and continued problems with dysplasia that were treated with laser treatment, and woke up with pain every day. Fortunately, he had an oral rinse that could alleviate some of that and made eating more comfortable. But he was always previously addicted and probably continued that addiction to sugar hard candies to keep his mouth moist, which led me to think about medicines and, you know, cough syrups and things like that. And in the health professions, we ought to be concerned about medications that we prescribe that are over the counter that contain sugar. And I just wanted to hear from members of the panel what is being done in different countries with regard to sugar in these kinds of over-the-counter cough syrups and things like that. If you'd like to comment.
I mean, in the UK, the sugar-free would always be prescribed as the first option. I don't know whether that's the same in the USA.
In the US for children it is, but I'll tell you when it comes to other products, look at vitamin pills. And Kristen showed the chewy gummy candy things, but look at our vitamins that you can buy for children. You can buy Flintstones, you can buy gummy bear ones, and finding one that doesn't have high fructose corn syrup or sugar is impossible. They either have one or the other. So, you know, again, it's getting back to manufacturers and the cell products. I was once on a panel that, I don't remember if it was Adente or Pharma Group, and Adente was a participant, that looked at product inserts to give with, this was antidepressants and antipsychotics to deal with the dry mouth issue. Because of and the appetite issue to deal with the increase in decay they were seeing in patients with mental health, with mental illness, and other patients on all these medications. That went nowhere, unfortunately. But you speak to a very important point.
In Berkeley, which passed the soda tax, they do have a committee looking on how to spend the money. So I feel in dentistry, you know, we have the solid research. Now we're the tag along, and when the taxes go through, children's oral health is left off. So maybe some comments on my irritation.
Thank you, Steve. Who'd like to pick that one up?
Well, I think maybe you should move to the UK because
No, we've often told him that.
I'm joking. Because Public Health England have stated that the sugars reduction is a priority for obesity and dental caries, and I was delighted to see that dental caries got in there. And I've heard several presentations now being given by people from Public Health England at stakeholder groups, and the caries word is on the agenda, so that's very pleasing to me.
And the tax, if it's taxed in the UK, will be used for dental health?
I don't know whether a tax will ever come in.
I don't think that's going to happen.
And I just wanted to ask you, Steve, whether you had attended any of those meetings to get your voice heard regarding some of those initiatives. And I think that's what I would encourage, is more dental voices getting out there and getting the message out.
Dr. Benzian?
Just a quick comment on the use of tax money. Some countries have found the solution to earmark those funds to go into health promotion foundations. Thailand is a big example for that. It generates a huge revenue. Taxes from tobacco, other sin taxes can go into such funds and be used for health promotion purposes. That has worked very well, and WHO actually recommends it. My comment is slightly related to your first irritation. While you feel hijacked by the chronic diseases and the whole movement that has come around that, I see this more as an opportunity. And I'm actually thrilled to see that WHO has taken oral health, or the direct relationship between sugar intake and caries, as an example to highlight the link between sugar and the chronic diseases. We should not be fooled by WHO's interest in caries. It is not a sudden awakening that they feel that oral health is important. They use this as a vehicle to promote lower sugar intake for the sake of chronic disease prevention. And I was wondering, since you were involved in this process, Paula, what was the discussion WHO internally on this? Was there anybody speaking in favor of oral health? Was it your WHO collaborating center raising this issue as a good argument and making a case for better prevention and control of chronic diseases? Because the second part of my remark goes into what are we doing with this information and with this guideline as a profession and as advocates for global health, where we feel that our area that we care for is so neglected and doesn't get the attention that it deserves. How can we use and leverage this guideline to increase priority for oral health?
Thank you, Habib. Who'd like to pick that one up?
Well, I mean, I wasn't party to all the early discussions with WHO when they were doing the priority setting and scoping. So I became involved in the process once it had been decided that they were going to look at sugars and caries. And I concur with what you say, that the data on dental caries enables the limits to be set, whereas it's more difficult to do that with respect to obesity, because we just know that less is better, because it's an energy effect. That said, the WHO do write into their priorities that we need to consider oral and systemic health and the links between oral health and systemic health, and they are very aware of the cost implications of dental diseases. I mean, it costs between 6 and 10% of healthcare budgets in industrialized countries, and in developing countries, it would exceed, the treatment of dental decay would exceed the entire budget, and they are very aware of that. So I think it is on the agenda, and I'm going to keep it there, I hope.
Thank you. Thank you.
I think today was a wonderful, wonderful example of how research really informs policy and how policy can have an impact on research. I thought all of your presentations really spoke to the interplay between those. And as somebody who's a dental health policy researcher here at UCSF, I often feel a bit lonely because there's lots of clinical researchers and then there's these wonderful health policy researchers, but not a lot. So I hope that this is the beginning. And when Kristen came, I was so thrilled. So I feel like there's another one. I really hope this is the beginning of more of these types of discussions, because I feel like that the dental school can be really enhanced in terms of the application and the relevance of their clinical research and their basic research with these connections to the health policy. And as you've shown, the health policy is only as strong as the research that informs what they can actually create policy on. So I just really think it was just a wonderful, wonderful way to bring those two things together and on an issue really on a global scale. So that's my comment. And my question is, for you all, thinking about sort of this dearth of policy generally being paid attention to in many of the dental education community or dental realm outside of sort of more outside of organized dentistry and the policy positions that they have. What other ways besides making an individual comment, on a regulation, what other things do you think that we should be doing in terms of our education and in terms of our global health efforts to bring more policy competence to our professionals so that they can engage in this broader advocacy arena?
I'll start. I think one of the things we need to look at doing is one of the points you made, and that's collaboration. This is a unique meeting, and I really congratulate Ben and his team on pulling together nutritionists and dental health professionals and dental policy people, because I think that's a first. And to me, to be that interplay in the audience together, on the panel together, is something we need to promote more of. I think going together to these types of meetings, doing the research together, rather than thinking, oh, I can pull in the oral health stuff, I know it, or the dentist thinking, I can pull in the nutrition stuff, I know it. But bringing all the experts together will lead us to a lot of those changes. And I'll just put in one plug, and I'm sure Paula will join me, and that's the IADR has a lot of organizations, one of them being the Nutrition Research Group, which is a great venue for pulling some of these people together to put stuff out there.
In relation to Professor Moynihan was saying how difficult it is to measure frequency in human studies. And that's where I think Professor Glantz was really right on, because in caries, animal caries, we have so standardized the animal model, we can control the microflora, and Professor Koenig in the Netherlands, well, he did it already in Switzerland, developed a feeding machine. So it worked like a lazy Susan, and you could feed a rat 4 times a day, 8 times a day, 24 times
We're going to introduce it for dental students.
So it really, I think we shouldn't sell animal studies short, because they can get us information which we couldn't possibly get with humans. And finally, I have a question for you. You referred throughout your presentation about percent of energy intake, and I'm used to saying percent caloric intake. Is this a difference between America and the United Kingdom, that we are 2 countries separated by a common language?
That's exactly it. Yeah.
Thank
Energy,
you,
calories.
Good. Ben, I'll turn it back over to you. Thank you very much.
So just a few more words. We've invited Dr. George Taylor to step up to the mic and give a bit of a reflection on our afternoon events, what we've heard from our esteemed speakers. And it's my pleasure to turn it over to Professor Taylor, who's, in addition to his distinguished research career, was the man who hired me. So I'm always indebted to him for his good decision making.
Thank you. Thank you, Ben, and thank you for accepting the offer. That was a tremendous move on our department's part, and we continue to, and the school's part for that matter, and we continue to see the benefits and appreciate the way that your career is growing, and as well as the contributions that you're making as we move forward. I think having a reflections at this time is a bit anticlimactic, given the questions that have been asked, given the comments that have been made to these these excellent presentations. We've started from a clinical point of view, I would say, with Reva's presentation, giving us some perspectives on relationships, and also the fact that it's more than a actually more than a two-way relationship. This is what I got got. I've been thinking about bidirectional relationships, but actually Reva's presentation gave us some perspectives to think of this in multi-dimensions. And this is pretty much one of the themes of today as we think about adaptation, interventions, as we think about strategies for function, and in terms of oral cancer, oral facial pain, including muscles and joints, including the oral lesions, what kinds of adaptations, the whole notion of enjoying, not only just enjoying food for nutrition, but the cultural component. I think that rang very loudly, that we want our patients to be able to not only function, not only attain adequate nutrition, but to enjoy their diet and enjoy their diet on their own terms. I think that's a very powerful concept that we would think about. It helps us in how we would think about our patient education, and also helps us in how we would think about our healthcare professional education. And that takes us to the other point, and another point, not the only other point that Reva made in it. And she drove the point home to me about not only about interprofessional collaborations, coming from, first of all, interprofessional education, and then interprofessional practice, with the focus on diet and with the focus on nutrition. I'm happy that you shared with us the model in terms of health and nutrition risk assessment, the way that we need to triage our patients. And I would also interject, it stimulated me to think about triage the way that we think about our patients. This is another issue for us to become more aware of the health literacy, the nutritional health literacy, the dynamics that come and go into play with diet, and the relationship with diet and nutrition. And that certainly comes to play, certainly comes to be very clear when we talk about nutrition, sugar. And that would take us to Kristen's presentation. And I think just to open our eyes to how the sugar industry manipulates research. And it's not just the manipulation of research that Kristen shared with us. It's also manipulation of manipulation of policy. We had Beth raised some important questions about and made some important observations about how the way that policy transcends all we've been discussing today. I took note of one comment where I think Ernie made the comment, made a distinction between the scientists and policy decisions. I'd argue that perhaps we need to think about the clinical scientists, the epidemiological scientists, and as well as the political scientists. So I would argue that there perhaps is not that distinction when we talk about political science, policy, and political science, and we think about the clinical and the laboratory scientists. I appreciate that. I think we all appreciate a representation from the American Dental Association and the California Dental Association in terms of the advocacy, in terms of the support of research, and also in terms of supporting the ways in which the funds from the taxation for the sugary beverages could be used. I think those are things for us to think about. They are strategies that are important to pursue. Finally, I'd like to mention, I won't say very much about Paula's presentation because it was the most recent one, and we've had quite a bit of discussion already. The insights that we got in terms of the WHO guideline development, I think, is quite important. Understanding the grade criteria, grading of recommendation, assessment, development, and evaluation, a way of assessing evidence. The question about evidence came up. We had some discussion about the validity and credibility of different types of evidence in terms of moving our knowledge base forward as we look at diet, nutrition, and most particularly sugars in today's meeting. I appreciated that we had reviews and evidence from those reviews. The systematic reviews, we learned about the ability to conduct meta-analyses or the limitations of conducting meta-analyses on the evidence that we learned about today. Also, we talked a little bit about assessing carious lesions. A practical point for us as we are moving our curriculum forward right now, we're in the midst of developing a more systematic, more evidence-based approach to assessing caries in a way that we can continue to make decisions about management of those carious lesions as we go forward. I think the types of sugars, the notion of the distinctions of the kinds of food, the starch-containing foods, the different distinctions between processed food, processed starch, cooked starch, and non-processed starches, the impact of paying attention to all those different dimensions in terms of diet and in terms of their role, the role of sugar in caries is important. So to me, one of the, not only the facts, not only the evidence that we received has been so helpful, but it's also the whole day has been a way of thinking about all of these issues. And not only thinking about them, we've also had strategies suggested on what to do. And that takes it to another level. And I think that's probably what would put the highlight on this afternoon's symposium, is that we had evidence. We talked about designing studies. We talked about conducting studies. We had specific conditions to address, and then we had strategies, interventions, and once interventions clinically we talked about, and also policy interventions. The whole notion of thinking of how to think better about all of the topics that occurred. So I'd like to give a great round of applause to everyone who presented today.
We have many people to thank who made this event possible. Certainly all of our speakers, many of whom came a long ways to be here. Everybody who shared their thoughts and introduced speakers, everyone who gave comments and participated in the panel. Thank you. Made this a true, ongoing, and engaging conversation. So just two last very important final thank yous, and of course to our Dean, John Featherstone, whose leadership, his support, moral support, and of course financial support from the Dean's office makes this day possible. From the very beginning, as you heard, global health has become a priority here at our school, and I hope we can say that for many years going forward. So thank you. And of course, to Dr. John Greenspan, who started this whole event. And I guess, darn it, we're just going to have to keep doing it. So thank you for everything you do. You've been a mentor to me as well as many, many other lucky professionals. So you've been wonderful. Thank you.